here joining us today. Thank you all so much for joining us for another Wednesday installment of a 30-minute VMR. If my face looks a bit melancholy today, it is because, unfortunately, my usual co-pilot, Charmine, is not able to join us today. Some storms have been battering the West Coast and the San Francisco Bay Area, and it has knocked out her power. But if you can't tell that I'm melancholy, it is probably because I am also simultaneously extra excited, because that means that I get to discuss with Yasmin today, who's going to be stepping into the co-facilitator seat, a frequent flyer on the Thursday morning VMR facilitations and a new pilot on the Wednesday sessions. Yasmin, how's it going?
Hello, everyone. I definitely have some big shoes to fill in today. Hopefully, Dr. Charmaine will be safe right now. And I hope everyone that's watching us from California is not having it too bad. But yeah, I'm really excited to discuss today with Dr. Jag. I think it's the first time I will discuss with you. So I am very eager to learn from you and do this the best I can.
The excitement to learn is mutual. We're gonna have a good time. We'll keep it light, we'll keep it fun, and we'll keep it flowing. We are now down to 25 minutes left. So I will just say that we have a dream team today. Promise is going to be scribing for us, and you can stick around to the very end to hear some awesome teaching points from Deborah. And in the meantime, I will kick it over to Shema, who has a case for us that it sounds like is hot off the presses, which Shema's cases are always spicy, and it sounds like this one might be even spicier. So we can go ahead and get started. Yasmin, do you want to take the sort of first discussion of the first aliquot, and then we can just go back and forth each aliquot?
Of course.
That sounds good. All right, Shema, take us away.
So, okay, starting with the first aliquot, we have a 39-year-old female woman who is presenting with right-sided lower abdominal pain, nausea, vomiting, fever, and with chills 7 days after spontaneous vaginal delivery. And I will stop right here.
Okay, so first thing, in a female patient with lower abdominal pain, I will definitely look at gynecological issues such as ectopic pregnancy, but she already had a spontaneous vaginal delivery. So that can be out of my differential diagnosis. The only thing I'm thinking about the spontaneous vaginal delivery is if there is any remnant of the product intrauterus that could cause this fever. Exactly, I can see that in the chat. Ella already said that. Yeah, thinking about if there is a remnant. So posteriorly in the next aliquots, hopefully we have an ultrasound to see if there is anything else. Also, part of the questions that I would do to this patient is if she has any kind of discharge, if this is a serous inguinal discharge. I don't know if I said it correctly in English. If it's purulent, if it's only bloody, I would definitely think about that. Other causes may be abdominal, like in GI tract, appendicitis. I will think any gastrointestinal issues. But with this particular personal history, I would go to gynecological exam. What do you think, Jack?
I think your analysis is brilliant. I appreciate so much the way that we are sort of actually working up two simultaneous parallel paths here, right? One way to frame this case is to say that the recent spontaneous vaginal delivery is directly related to this acute onset abdominal pain, which I think is the appropriate hypothesis to prioritize, given the morbidity of the postpartum complications that you mentioned, whether it's retained placental products or an ascending infection into the uterus or another intra-abdominal complication after a spontaneous vaginal delivery, for example, ruptured uterus, a postpartum hemorrhage, or some sort of other intra-abdominal complication. We also have to evaluate that and say, what if there's a possibility that the abdominal pain and the recent vaginal delivery are true, and unrelated, right? And so approaching this through the lens of abdominal pain in general, as well as postpartum pelvic pain or postpartum lower abdominal pain, as being two possible lenses that we can explore here. I think that you framed it absolutely brilliantly in saying that, again, we are going to prioritize the postpartum complications first, but be prepared to turn our attention to other causes of abdominal pain that are unrelated to the postpartum period, right? I think the other thing to think about here is not only prioritizing DX, but also prioritizing TX. And so oftentimes in these settings, when we're decontextualized from the clinical environment in which this situation is unfolding, right, all of our cognitive energy goes into saying what's the cause, but we also have to ask ourselves for the possible consequences of what could be going on and what may need attention up front. And so this is a situation, any acute abdominal pain, but particularly acute abdominal pain where there may be hemorrhage or disseminated infection on the hook. We're looking closely to see, are we going to be reaching for antibiotics, fluids, and/or blood products in the setting of diagnostic uncertainty so that we can manage the potential complications that could be unfolding as we search for the underlying diagnosis. And so those would be sort of the two domains of focus here. Again, postpartum or post-vaginal delivery abdominal pain, which Yasmin walked us through brilliantly, abdominal pain in general, and then also the management aspects here, really prioritizing fluid, blood products, and possible antibiotics as the management tools we may reach for in the hunt for an underlying diagnosis.
Amazing discussion. So I will now give you a little bit more information. So to the onset of the symptoms, it was 2 days of feeling unwell, and she also had generalized abdominal pain. She had a loss of appetite and she was unable to eat. The other symptoms that she had 4 episodes of loose motions with watery stools and admission, lethargy, and difficulty standing. And she also reported a mild dry cough for 4 days and a sore throat. And to her vaginal delivery, it was an uneventful vaginal delivery of a live-term male. Through her past medical history, her pregnancy had been complicated by chronic hypertension. It is now, it was controlled under labetalol. And she also had gestational diabetes, which is now managed with metformin. And I could also give you the vitals if you want. Okay, so she had a temperature now of 37.1 degrees, respiratory rate of 20, a pulse rate of 130, blood pressure 129/69, and her O2 set was 99% under room air. Yeah.
Take us away, Yasmin.
Okay, so now I'm looking at this as I instantly thought about infection, but with that temperature, although it's not going to discard it, I will think of any other reason for why my patient is having a lower abdominal pain. It could be, I will think any kind of colitis, I will think diverticulitis, and I will also, if she has been having for episodes of loose watery stools, and after these days, I will think maybe something infectious, but not that acute, because there is no fever, although that those are my two scenarios, something that could have been infectious. But again, I would like to know if there is the characteristics of the pain, if they radiate, if it's how intense they are, because in the lower abdominal area, we can have many other things, including also thinking even about splenic issues. But then again, with this non-gastrointestinal etiologies, I will think maybe even urinary colic can cause this kinds of lower abdominal pain. So I think it's, for me, it's very non-specific. What do you think?
I completely agree with you. I think one of the challenges I think that you're highlighting here, right? If we just were to run back the transcript of what you just shared, right, the potential scope of pathologies that could be causing these symptoms is enormous in terms of the list, right? And I think really what that shows us is the difficulty it is to make progress beyond framing general illness severity in any patient who has acute abdominal pain with the history and the vitals alone, right? So many of the symptoms that we might use to localize problems within the GI tract, or that we might use to hang our hat on, for example, in this case, things like loose watery stools, so many of these symptoms can happen with anything from benign gastrointestinal problem or benign intra-abdominal problems like gastroenteritis to sinister intra-abdominal problems like an aggressive infection, an obstruction, or even something like perforation, right? And so if the scope of severity can't be narrowed based off of findings like watery stools, right, it's very hard for us to really narrow our differential and to localize the problem, or to at least prioritize what organs could be involved, right? And this holds true in individuals with acute abdominal pain in general, and the postpartum nature of this abdominal pain only widens the lens of potential causes, which only makes it more difficult to make progress. We have to ask ourselves, right, there is this sort of recent syndrome of things like a dry cough and a sore throat, right? And so there's the possibility that actually these systemic symptoms are related to a systemic viral illness. But in my mind, those symptoms are taking much less priority than the acute abdominal pain, because the potential causes of acute abdominal pain can be so morbid. And so while the journey on this with these sort of more systemic symptoms compatible with a viral illness, our journey may take us to ultimately saying this is influenza, this is COVID and normal postpartum pain. But the journey to that destination has to go through our acute abdominal pain DDX, which is you, I think, brilliantly articulated, guys. I mean, it's really difficult to make progress on, at the very least without an exam. And oftentimes, if there is possible intra-abdominal complications or severe intra-abdominal disease, imaging as well. And so in this case, I'm honestly going to say that it would be dishonest and inauthentic of me to say I know what's happening or I'm able to make progress based off of the information that we have, beyond saying that I'm concerned about this acute abdominal pain and in this individual who has risk factors for multiple different severe intra-abdominal diseases, whether that's infectious problems, vascular problems, or some of the other potentially severe causes of acute abdominal pain like perforation or obstruction. And so I think that is sort of where the progress that I feel like I'm able to make. But I think I'm very eager to see what types of localization the exam can help us with, and then also hopefully we may either get an answer that precludes imaging or cross-sectional imaging to help us hopefully narrow things.
Amazing discussion. So I will now give you the physical examination. So on the physical examination, there was abdominal tenderness over the right iliac fossa with rebound tenderness. Roping sign was positive. And in addition, there was a uterine subinvolution of 20-week size. On extremities, there was no calf tenderness and no swelling noted on the leg. We also performed a speculum examination that was unremarkable. And there was, now sorry for my pronunciation. I will write it down because it's too embarrassing before. Please, someone can say how I pronounce this one. It was present in small amounts. Can anyone pronounce it?
The pronunciation is lochia.
Ah, okay, yeah. Lochia was present on small amounts without foul odor. And yeah, and I could also give you the first labs if you want.
Yeah, that sounds good.
Okay, so in the blood studies, the white count and neutrophil count was normal. And she had a lactate of 2.5 millimole. The APTT was prolonged with 40.5 seconds. The derived fibrinogen was 5.18 and normal, the upper limit was 4. The thrombin time was 17.5, so it was still normal. And INR was slightly elevated with 1.25. And I would stop here before giving more information.
Okay, so far we don't have white blood cell. I would have expected it that if this was an infection, or we would have a higher white blood cell count. But now I'm trying to anchor a little bit on the PTT, a prolonged PTT, which in women this age, I could think about systemic lupus erythematosus. Or also, there are other causes such as hemophilia, vitamin K deficiency, and even think about von Willebrand disease. But if with this PTT, this prolonged, and also thinking, if we had a disseminated intravascular coagulation, like Hans in the chat has brilliantly proposed, I would think we would have, I don't know, swelling, we will have petechia, we will have other issues. It would be more, there will be more symptoms, I think, so far. So I would definitely see if this patient has a lupus. I would like to know if she has this positive antibodies for it, just because she's in this age where it normally presents. And also, I don't know if you have past medical history, if this spontaneous vaginal delivery was like on the time it should be, and also if she had other issues to get pregnant, or issues during the pregnancy. That's something I would have asked. But yeah, I would definitely look for an autoimmune or coagulopathy, yes, because it also stands up my prolonged INR. It stands out to me. So that would be right now my differentials. What do you think?
I think it's fun. I think brilliant. I really appreciate the way that you're bringing in the recognition of these abnormal coagulation findings. And I think I'll just sort of play with what you alluded to there, and I will ask you, in somebody who may have let's just hypothesize, in somebody who has a coagulopathy, you mentioned something like lupus and the possibility of antiphospholipid syndrome. What types of hematologic complications might you see in a patient like that? Would you see bleeding? Would you be more worried about clotting, or potentially both?
And a person that has a coagulopathy, especially for autoimmune diseases, I would expect, if I'm anchoring myself in systemic lupus erythematosus, I would expect petechiae and cytopenias. These cytopenias could be white blood cells, red blood cells, platelet, or the combinations of all three. And obviously this inflammation everywhere, the ites that are very prevalent in systemic lupus erythematosus, that pleuritis, pericarditis, myocarditis. That's why I'm not anchoring also on that, because I think that if she had more towards the autoimmune path, she would have had any other symptoms.
Excellent, excellent. So what I'm hearing from you is sort of thinking about the general systemic complication, which I think is absolutely spot on. And then if we think about the actual bleeding or clotting problems that someone can develop, would you be more worried about bleeding or more worried about clotting in a case like this as a cause of acute abdominal pain, for example, or potentially thinking about both? I
will be worried about both, but more for clotting.
Yeah, tell me more. Tell me more.
I will be more, especially because I think it's more difficult to destroy the clots than to stop the bleeding. We can use a myriad of things to stop the bleeding. I believe, I'm not very sure in the postpartum period, but tranexamic acid maybe. But to destroy clotting, especially if this patient has an autoimmune disease or any other inflammatory process, it would be more difficult to control.
Yeah. So from a management perspective, that is absolutely spot on. And I think you also mentioned something really important, which is the fact that, alluding to the time course here. postpartum hemorrhagic complications, we might expect to see a little bit earlier in the postpartum period, whereas as we move to days afterwards like this, right, there's potentially that becomes less likely, and we might think about other potential vascular complications like clotting. And the reason that I'm reaching into the sort of vascular space here as a possibility, in addition to what Yasmin mentioned as the sort of disproportionately elevated APTT, thinking about the possibility of something like antiphospholipid antibody syndrome and how that could predispose to clots. The other element where vascular complications come in is in our general acute abdominal pain framework, right? If we think about the categories of disease that can cause acute abdominal pain, a mnemonic that I have found helpful to use is VIPO. So we can have vascular problems that cause acute abdominal pain. The I stands for itis. So any inflammatory or inflammation in any organ can cause acute abdominal pain. And then the P stands for perforation, and the O stands for obstruction. If we say, well, which of those can give people severe pain, but not necessarily cause other signs of underlying infection like fevers or a leukocytosis, right? Vascular complications potentially come into the fold there. We usually think about it in the setting of acute mesenteric ischemia, but we can ask ourselves, are there any postpartum vascular complications that individuals can develop? And the answer to that is yes. There can be possibly things like ovarian vein phlebitis, ovarian vein thrombosis that develops. And then sometimes if there's also ascending infection within the uterus, like endometritis, there can also be ovarian vein septic thrombophlebitis as well. And so Yasmin, I think you picked up on a potentially really valuable laboratory finding here in the isolated elevated PTT to ask the question of, is there a clotting risk that may exist beyond just the postpartum period for this patient? And that is one way that we can take that into the fold. But I will say the vascular possibility still has to sit underneath the infectious possibility, because I will ask all of you, which of the following carries more diagnostic weight? Acute abdominal pain signaling a possible intra-abdominal infection, or absence of a leukocytosis arguing against an infectious process? In other words, can you see infection without fever? Can you see infection without leukocytosis? I'm seeing some yeses come through. I would say yes. And so I have been faked out so many times by thinking that somebody doesn't have an acute intra-abdominal inflammatory process because there's no fever and no white count, and they have cholecystitis or cholangitis or colitis. And so in the postpartum period, right, we still have to think about things like endometritis as a possibility, or ascending streptococcal infection, a very common postpartum complication as well. But we may also be attuned to the possibility of a vascular complication as well, given what you had mentioned, Yasmin. And that matters because it may influence some of the diagnostic tests we get. CT scan is great for seeing organ-based infection, but sometimes to see if there's a clot in the area, we may also need ultrasound with Doppler imaging to get a sense of that. So this may bring into the fold another diagnostic that we may not always pursue for acute abdominal pain, but that we are going to use for acute abdominal pain in the postpartum period like this.
Amazing discussion. I really love listening to you. So now I would give you the other lab findings. So the liver function profile was completely normal. Her renal function panel revealed a picture of AKI. We didn't do any D-dimers, and they performed an abdominal pelvic ultrasound, which was showing an intramural fibroid and congested veins surrounding the uterus in keeping with postpartum status. The appendix and the ovaries had not been visualized. And also during the transvaginal scan, there was also severe probe tenderness. And the last thing that I have for you would be the CT scan. Due to the time, should I tell you the finding of it? Okay, so on the abdominal CT scan with oral and IV contrast, it was showing a tubular-like structure extending from the pelvis to the abdomen up to the right renal hilum level, which was not separable from the right adnexa. This mass structure was measuring 11 times 3 centimeter in size, and this mass had it was also showing some fat stranding extending from the retroperitoneal area to the renal level. Yeah. And the appendix was seen in the right iliac fossa with normal appearance, normal size. Yeah, that is everything. And the blood cultures came positive for group A strep. That's everything.
Okay, so the first thing when you mentioned the severe tenderness, intramural fibroids, the first thing that came to my mind was a issue of degenerated leiomyoma in patients referred for the history of fibroids, that normally there are many women that don't really know they have them. And when this happens, which is a very common tumor of the female reproductive tract, they grow during pregnancy, and they can cause pain. And when it degenerates, it can actually give us these kinds of medical presentations. But then you mentioned that there is a tubular-like structure extending from the pelvis to the abdomen. So my second differential diagnosis will be kind of obscure. It will be an epiploic appendicitis that can be a little sac that sits above the intestine or in pelvic area, and it can actually inflame. It is relatively unnoticed. It can go relatively unnoticed, but again, those are very obscure diagnoses that come to mind. Because honestly, if you look for it, it's not very common. This appendicitis can cause the condition of ischemic infarction due to any, I don't know, torsion, spontaneous thrombosis, especially in a woman postpartum. And we have the most common manifestation of this appendicitis is lower abdominal pain, early satiety, I don't know if I say it correctly, satiety, nausea, vomiting, diarrhea. But again, this is a very obscure differential diagnosis. What do you think?
I think I'm just enjoying so much hearing you reflect on this, and just the breadth and the expansiveness and the speed with which you're able to pull out these different disease associations. You know, I think we have I think an important clinical finding here, and I appreciate the way that you were trying to, or the way that I think you were very effectively linking some of the other underlying uterine pathology to what could be going on here. I see what you just put in the chat, which was going to be, or which I think is absolutely where my mind is going to here, which is, you know, when we see a sort of inflammatory fluid collection within the intra-abdominal compartment, almost invariably that is going to represent an intra-abdominal or an intrapelvic abscess. What then becomes the next question is, how did it get there, right? What is the underlying structure that is going to be the culprit for this? And I think in this case, as Madalena was alluding to, and as you were alluding to as well, right, if we say, well, what are some of the postpartum infectious complications that we could see, and what structures could be involved here, right? Certainly anything within the reproductive tract is potentially on the hook here. And what really advances the case forward and helps to crystallize things here is the blood cultures. Because if we think about what are oftentimes intra-abdominal or intrapelvic organisms, right, those are usually gram-negative rods and anaerobes. But if we see here, it seems like what we are dealing with here is actually group A strep as the ultimate blood culture, which I usually think of as oftentimes a skin and soft tissue infection in sort of the gram-positive category. But the other place where we can see group A streptococcal infection is when it causes a uterine infection. And so the blood cultures here combined with these imaging findings make me wonder, say, okay, is the sort of chain of reasoning that we can link together here to say that there was a postpartum endometrial infection or uterine infection with group A strep, potentially moderated by the fact that there's fibroids which can disrupt the uterine wall? Did that increase the risk for this group A strep moving from the uterus into the fallopian tubes? And then that could cause a tubo-ovarian abscess, which, right, gram-positive organisms can march across and cause abscesses very, very fast. So is there potentially we went from the uterus to the fallopian tubes to this fluid collection that has now moved into the space kind of throughout the intra-abdominal compartment. That's one way to potentially conceptualize this. And I think given the fact that it's difficult to separate the fluid collection from the adnexal structures, seems like it's a possible culprit here. But the thing that I'm keeping held in the back of my mind is also the question of whether or not there is potentially a clot there as well, not because it's particularly common, but because it would potentially change management here, right? If we think about an infected clot, it doesn't just become an infection problem, it also becomes a source control problem. And sometimes clots can predispose to infections, but also sometimes infections can predispose to clotting. And so the fact that we're dealing with we see this venous congestion, which sounds like it's compatible in the postpartum state. I would also say that I want to fully falsify the possibility of a thrombophlebitis in the venous structures around this area, because again, it would have a big impact on management and source control here. But I think the idea of a tubo-ovarian abscess or underlying uterine infection complicated by an intrapelvic abscess seems like a compatible DX here, and group A strep is certainly a compatible organism in the postpartum period.
So great discussion. So the final diagnosis here was, as you already mentioned, this dilated tubular-like structure with the surrounding inflammation. It was typical for a thrombophlebitis of the right ovarian vein. So she was diagnosed as a postpartum ovarian vein thrombosis, which was manifesting as like acute, it was mimicking acute appendicitis. Yeah. I have to say I chose this case because I did some QBanks question, and there was some similar case of right-sided abdominal pain. And I didn't know that most of these ovarian vein thrombosis are on the right side, like 90%. And yeah, then I found this open source case and thought maybe would be some also for other people something new to discuss.
This is an amazing diagnosis. I actually, if I'm not wrong, it doesn't really, it's a very rare symptom occurring in around like 5% or 1% of vaginal births. And it is, yes, it is normal in the right side if I'm not remembering wrong. And it makes the presentation is very much like appendicitis. But yeah, I didn't really expected this.
I think, Yasmin, this is, first off, just an absolutely brilliant job discussing this case. It was so fun to get to think through this with you. And I think both there's just the curiosity and the openness and the way you just dive into these cases is so fun and honestly inspiring for me to see. I want to channel more of you when I come into these discussions. So absolutely phenomenal job. Jema, I'm curious to know how it sounds like the clot wasn't necessarily seen on the ultrasound. I may have misheard that, but I'm curious how you all came to the ultimate diagnosis of there being a clot there.
Then we also did some other imaging, which were maybe, let me check. It was showing a thrombosed right ovarian vein, so it was better visible there. I could show you the other pictures. I'm sorry.
No, that's okay. That's okay. So was that seen on CT scan or ultrasound?
So it was seen on CT scan, but not on ultrasound. We didn't do the Doppler. We only, yeah.
I see. An amazing case. And then also I see a couple people asking the question that I'm also curious about, and it's you may not have this information, but was a workup for things like APLS pursued or any of those antiphospholipid antibodies, or did it all seem like this is so compatible with the postpartum period that we don't need to work up for a hypercoagulable state?
Well, it's a good question. The hematology team, we just started for an enoxaparin and warfarin for a duration of 3 months, but we didn't do these other research. But so we also thought that this was postpartum because usually this is most common, I think, 3 or 5 days postpartum. Yeah. Awesome.
Shema, thank you so much. This was so much fun to get to think through, and I have a lot of learning to do. Again, finding I think just that wonderfully enjoyable space of the edge, like finding the edges of one's knowledge and having all the fuel to start to take things further. So I want to say thank you for bringing this case. Yasmin, again, thank you again for a phenomenal discussion. I'll turn it over to you if you have any final reflections, and then let you kick it over to Deborah for what are bound to be some epic teaching points.
Yeah, honestly, thank you so much for this opportunity. I also have a lot to learn from this, to always remember that in this case with a female patient postpartum, even if it's very rare, thrombosis must be one of our differentials too, especially because all of these physiological changes predisposes the women's physiology to this hypercoagulable states. So thank you so much. And also to take into consideration that even if the symptoms are not very, are not conclusive or may look not so important, at the end, we cannot discard any diagnosis with these patients. Thank you so much.
All right, Deborah. Brilliantly said, Yasmin. Deborah, take us away.
Hi, everyone. Great discussion. Thank you, Shema. So going for the teaching points, and a lower abdominal pain in a woman, we can think about gynecologic causes and like an ascending infection, retention of the placenta, like a remand from the delivery. So in this case, we focus more on the postpartum complications. And then we have to always ask about the cause and then the consequence. That could be an hemorrhage, an infection. And going for the GI causes could be appendicitis, a diverticulitis, or infections too from the GI. And we need to know more information about how is the pain, if it's radiated, the severity, the symptoms, and that we can think if can be related to systemic syndrome. And then the patient presented on the lab a prolonged APTT. So we thought that could be a lupus or disseminated intravascular coagulation. And we have to think about it, the systemic coagulation by like bleeding or clotting. In this case, we said that could be more chance of being a clotting and could be more difficult to control. And we always, when we have acute abdominal pain, we have to remember about the VIPO, that is vascular, the itis, like inflammation, infection, the P for perforation, and the O for ovarian. And then when came the image with Yasmin, brilliant had about that could be a myoma, apoptotic appendicitis, or maybe could be a tubal ovarian abscess that could be from an infection. So yeah, thank you everyone. I hope to see you all tomorrow.
See y'all. Have a great rest of the day. Thanks again, everybody. Deborah, I'm very happy to see the love you're getting on the teaching points. It is very deserved. Bye, y'all.
Bye.